Well, good morning, everybody. It's a pleasure to see familiar faces. It's my pleasure and privilege this morning to introduce Dr. Jeff Westcott. Jeff's a good friend of many in the group. I think many of you may know of him if you don't know him personally. He comes to us as the medical director of the Cardiac Cath Lab at Swedish Heart and Vascular Institute. He's a very unique individual, practicing interventionalist, but also a strong interest in medical informatics, decision support, appropriate risk use criteria, serves on the ACC Informatics Committee, and is actually having a major role in how the medical informatics of our practice in this country is going to be laid out and how it's going to work. Published a fair amount. We don't need to go over those, but it's this morning he's going to talk to us about atrial fibrillation, new pharmacologic stroke prevention strategies. It's just a pleasure to have you here, Jeff, and welcome. I'm sorry your visit can't be longer, but we're delighted to have you here and look forward to hearing from you.
Thank you. Thank you. So it is a pleasure to be here. Leave Seattle, rain, come to the beautiful, balmy North Country. So, you know, one of the nice things about giving this talk today is that typically, recently, I've been giving this talk under the handcuffs of pharma. And you know how it is, you got a slide deck, you got to go from A to Z, and you really can't talk about the comparative aspects of what this pharmacology is, which is really quite exciting, honestly. And so we've been looking forward to this, as I'm sure you have, for some time. So my disclosures, I do speak for the Pradaxa folks, and spent a lot of time with the Boston Scientific and Abbott Vascular folks. So I thought we'd start with a couple of questions. You know, typically we have audience response buttons, so you can be anonymous. You can't be anonymous here. So this is a case study, 62-year-old diabetic lady with a history of angina, long-standing hypertension. She has a 6-week history of exertional fatigue and palpitations, found to be an atrial fib on an office ECG. Modest rate at 94. Her echo shows an EF of 42%. She previously had DVT and was on warfarin for a period of time, but there was marked lability of her INR, and that was stopped. So question one is, what is her CHADS-2 risk score? So why don't we doesn't need to leave the room. So how many think her CHADS-2 score is 1? 2? 3? 4, 5. So 2 and 3 were the predominant ones. And the answer is 2. So we think, what are the components? So the kind of the pooling thing was her EF was 42%, but I didn't say she had heart failure. So if she had heart failure, it should be a 3. And now, because of her hypertension, she's really only going to be a 2. So if that's true, if she's a 2, then what is her risk, yearly risk of stroke? So would it be 0.5%, 1%, 2%, 4%, 6%? Okay, so one of the cool things about the CHADS-2 system, basically if you take the number and multiply it times 2 for the 1 through 4 CHADS, you'll get the right number. So the answer on her would be 4%. So here are the factors in the CHADS scoring system, as you all know. So whether it's heart failure, hypertension, age greater than 75, diabetes, stroke, or TIA, you add that up, and here is the risk. Now, it's probably not that accurate in the 5 and 6 category, but certainly 0, 1, 2, 3, and to me, the 0 and 1 end up being very important because most of those folks, the risk-benefit ratio is not in favor of putting these folks on an anticoagulant. And I must say, I'm sure you do too, you see a lot of people that are over-treated, and the kind of the belief structure is treat, 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 and then not deal with complications. I don't want to deal with complications. So this has been amplified with this CHADS-2 VASC score, which really says, well, if you're over 65, that may be a risk, and an additional risk over 75, and it adds on female sex, which is increased risk, and vascular disease. But if you take a look at how these parallel each other, it's really pretty close. So most of us are pretty simplistic, and I think the CHADS-2 score is, in my way of thinking, good enough. Okay. So if that's true then, so the risk per year is 4%, same scenario. So what should be the next step in her management? So A would be cardioversion. B would be antiarrhythmic therapy. No takers. C would be rate control. Okay? and D would be thrombus prophylaxis. Come on. So that would be the right answer, right? Because her rate was 94 on that ECG, so we don't really need to push that any harder. But she does need, I think, with a 4% risk per year of stroke, she needs some form of thrombus prophylaxis. So if that's the case, what would we recommend? So A would be warfarin, perfectly good choice, right? B would be aspirin alone, not a very good choice. C would be aspirin plus clopidogrel. Reasonable choice, we'll talk about that. And D would be Dabigatran. I guess E would be nothing because of that. Okay. All right. So I think the answers that I would favor in that particular scenario would either be A, warfarin, and was the anticoagulation clinic that dealt with her last time not that good? And could we do a better job? Could we give low-dose vitamin K at the same time we give warfarin and kind of smooth out her INR? Or should we use an alternative agent, and now we have a choice? She didn't have a choice before, and we could use the Dabigatran. So we basically have an epidemic of atrial fibrillation, and it's really driven the EP community. And if you take a look at projections out to 2050 of what's going to happen in the number of folks in this country with atrial fibrillation, the EP optimists would say that there may be up to 16 million people with atrial fibrillation by 2050. Baby boomers get older. We know that atrial fib is an age-related phenomenon. Plus, it seems to be that the incidence of atrial fibrillation is going up for whatever reason. Maybe it's Starbucks. I mean, I don't know what it is, but certainly it seems to be going up. So it's a big deal, and I think if you take a look at what happens, if you take all the strokes in the world, about 15% of them are thought to be embolic strokes due to atrial fibrillation. The economic impact is huge. And everybody who gets excited about healthcare first takes a look at what the national impact is. But I think to look at the human impact of this stroke is really even more imperative than dealing with the numbers. But the bottom line is that if you have a stroke with atrial fibrillation and you compare it to strokes that are not related to atrial fibrillation, the bottom line is that these strokes are bigger, they tend to be more lethal, and they tend to cause long-term sequelae that are above and beyond what the standard stroke is. So I think prevention in this particular population is horribly important. If you take a look at the stroke rate, and when I was growing up, I was thought, well, geez, if somebody has intermittent atrial fibrillation and they know it because they can feel it, only thing you need to do is keep them in sinus rhythm, and they'll know when they're in atrial fibrillation, so you don't need to bother to anticoagulate these folks. And that's really proven to be completely wrong. So, again, we have a whole lot of folks that, if you look at permanent AF versus intermittent AF, and low-risk folks, moderate-risk folks, high-risk folks, there isn't a big difference between these two. So AFib is AFib, and I think then you have to apply the CHA2 scoring system, decide what the stroke risk is per year, decide what the risk-benefit ratio is, to treat or not treat. But if you go ahead and you query people, you'll find, and you take a look at these trials. Now, most of these trials for AFib are really kind of garbage trials. Look at the end. I mean, these are little bitty trials, and we just don't have trials anymore that are less than 15 or 20,000 folks, right? But if you take a look at death, and the idea here is what's better, rate control or trying to maintain sinus rhythm? There really is no difference in mortality, and these trials are a little bit all over the board, but bottom line is there's no significant difference as far as death. There's some later trials that suggest that getting somebody back in sinus rhythm, perhaps by doing AFib ablation, may have a favorable mortality. So, but those are early data and more to come. And then if you take a look at embolic risk, as we already talked about, whether you are rate control or rhythm control is just the same. So if you go out and you talk to the primary care community and you say, well, what should we do about all this atrial fibrillation? I mean, regardless of what drug we choose. So we take a bunch of PCPs around the country and the respondents. So if you, misconceptions about rhythm control. So we're going to make every effort to put this person back in sinus rhythm and keep them there. And they would say, well, it helps avoid long-term anticoagulation. Yeah, so I'm going to put somebody on amiodarone so we can avoid putting somebody on warfarin. Or it decreases mortality, or it decreases stroke. So, you know, this is this is what people are thinking, and I think, unfortunately, cardiology needs to continue and educate the group about that. So the bottom line is that these folks are undertreated. And I think that that is really true. So I don't know, these data are 1999, so I can't say that that's current, but maybe it's going to be 70%, not 60%. Okay, so there are both physician issues and patient issues. There are a lot of patients that don't want to take rat poison. That's good. All right, so what we're going to talk a little bit now is a little bit more about warfarin, and as you know, I'm not telling you anything you don't know, so warfarin inhibits 279 and 10. 279 and 10 all have different half-lives. They're all produced by the liver. They're all vitamin K-dependent factors. But it's a very complicated pharmacology, as you all know. So we have drug-drug interaction. We have effect of liver. We have effect of the bowel and how much vitamin K is produced. We have dietary influences. So it ends up being a tough drug. So being that I'm kind of a country guy as well, and I know that this would resonate in Minnesota, I thought I'd show you some barns and some cows just to kind of bring this back. But what I really want to do is to show you a little bit about the interesting genesis of warfarin and what was it all about. And so it basically goes back to 1921. And there were a number of cattle that, as they were eating silage and they get scratches of their GI tract with silage, started to bleed to death. And it was a real disturbing thing. And what happened is a lot of the cows seemed to get better if they got fed alfalfa. So there's a guy called Paul Link who was working under the support of the Wisconsin Alumni Research Fund, WARF, who discovered that there was a compound, dicoumarin, in the silage that was causing the problem. And what happened is it was a particularly funny year, and the way they behaved, the clover was put in the silo and how it fermented was different that year, and it produced this from a molecule called coumarin. And coumarin is the smell. If you go by a clover field and it's just been cut and you have a beautiful smell, that's coumarin that you're smelling. But if you put it in and cook it just right, you get dicoumarol, which is an anticoagulant. And that was the genesis of that. So they figured out what was going on and then started to use it as a rodenticide. And the cool thing about it as a rodenticide is that the rats are really smart. So if Joe Rat comes in and he eats strychnine and he turns over and he goes feet up, Elmer Rat right next to him goes, you know, Joe ate that stuff, you know, he died, I'm not going to eat that stuff. And so they would not eat it. So if they knew they were eating some poison, this had such a delayed effect that the other rats couldn't figure out what happened. So it was a very effective rodenticide. But unfortunately, the label stock and all of our patients now think that they're on rat poison. All right. So does it work? Does warfarin work? And again, these are these small trials we talked about earlier. And again, they do work, even though the INRs in these trials were pretty much all over the board. Some of them shot to an INR of 4. Some of them were looking for an INR of 1.5. But the net was positive except for Canada. And all drug trials are negative in Canada for some reason. I don't understand. All right. So, again, I think one of the keys about the drug is that there's this narrow therapeutic window. And it's taken a long time to realize that it's in the 2 to 3 range. If you get less, then you're at significant risk for ischemic stroke. And if you get too much, then this is a big, big deal, and you have an intracerebral hemorrhage. And in the trials we'll talk about later, one of the great advantages of these new drugs is the incidence of intracerebral hemorrhage is significantly less than it is on warfarin. So it's a big deal. So there is a necessity to control the drug well. So how well do we do this? So I know that you guys have great anticoagulation clinics. We have good anticoagulation clinics, but still the majority of folks are still in community-based warfarin dosing, office-based, primary care, or cardiology. And if you look at the time in therapeutic range for these clinics, it's disturbingly low. So this would be 50% of the time the patient's in the therapeutic range. And you can get up in the 60-70% range. Well, there's nobody that's 70, but if you can get up here, that's good. In the clinical trial for Dabigatran, the time in therapeutic range was 70%. In the Rocket AF trial for rivaroxaban, it was 55%, and it was a real controversial number for that particular clinical trial. But the reality is that people are all over the board, even in well-run anticoagulation clinics. and it's a problem. But this is the real world right down here. Well, does it make a difference? So this is a slide meant to show cumulative survival without having a stroke is this axis. And what we're trying to show is that if your time in therapeutic range is very, very good, then the drug is incredibly effective at stroke prevention. If it becomes less over time, or just due to the clinic, now we're seeing a really much higher incidence of stroke, down to just a horrible thing. And now if you take a look at people that aren't taking any warfarin at all, it's better than if the time and target range is way off the board. So it's kind of a misnomer. Just because I have somebody on warfarin doesn't mean that I'm doing good. Okay? Alrighty, so how about antiplatelet therapy? So I had Mrs. Jones on warfarin. She had a GI bleed, and therefore I'm going to go to an alternative drug. I'm going to go to clopidogrel plus aspirin. Does that make any sense? Well, it's been studied. So if we look at the ACTIVE-A trial to begin with, that's to take a look at aspirin plus clopidogrel versus aspirin alone in stroke prevention. And in fact, the addition of clopidogrel is somewhat helpful. Okay? The stroke rates are reduced, but the bleeding rates are increased over aspirin alone. If you then randomize clopidogrel plus aspirin versus warfarin, what you see is a different story in that it's less effective than warfarin, and the major bleeding isn't changed. So if the reason you're doing it is to avoid bleeding due to warfarin, it's kind of not consistent with the data. Okay? Sometimes if you can't convince patients to take warfarin at all and there was no other alternative, then it certainly would be better to do clopidogrel and aspirin than to do aspirin alone. There's no doubt about that. Okay. So the oral vitamin K antagonist, the good news is that it's been around for a long time, fairly well studied, fairly effective if the INR stepped in the therapeutic range, actually very effective. Well-known and defined drug and food interactions. It's generic, so the cost of the drug itself is cheap. The cost of maintenance over the healthcare system is a lot more than that if you factor in the visits. And the belief is that it's easy to reverse. And this is kind of an illusion as well. So if I take somebody that comes in, they're having a GI bleed on warfarin, and I give them 4 or 5 units of fresh frozen plasma, how long does it take to normalize the INR, do you think? I'm going to give them vitamin K too. Best guess. 2 hours. And I think that would be a belief. I mean, most people would say that. So if I started with an INR of 2.7, at 2 hours I measure the INR, it's probably going to be 2.1. And the real answer is 7 to 9 hours to normalize the INR. Much longer than you think. Now, you can use the prothrombin concentrate. That does work faster, and some are available in the States now. There are about 3 or 4 of them available in Europe, like everything else. So you can get it down. But it's not immediately reversible. So the disadvantage, obviously, you need to monitor. You have to adjust the meds. There's interactions. Patients don't like it. Bad reputation. But so people aren't getting it. So let's talk about Dabigatran. And we've waited for these molecules for a long time because the thing that's cool about it is that it's oral, it's selective, it's reversible. It binds to thrombin, and it's on the lower part of the curve. I'll show you in a second. So it inhibits as well thrombin-induced platelet aggregation. And this is the cool thing. If you take the drug, you're anticoagulated in 2 hours. Done. Somebody's in a hospital with bypass surgery. They're getting ready to go home. They go into atrial fibrillation. You'd like to get them on warfarin before they go. You know it's going to complicate their postoperative care. You put them on Dabigatran and they're anticoagulated. And then you don't need to monitor it. So it's a ridiculously easy drug in many ways. There's no P450 drug interactions that you need to worry about. But we do need to worry about the renal status, and we'll talk about that. So where does it act? So remember we had 2, 7, 9, and 10, but where it acts is right down here, and what you're trying to do is to prevent the catalytic fibrinogen being cleaved to fibrin. That's what we're trying to do with all these drugs, so you're very directly affecting this. So this molecule gloms onto thrombin, changes the geometry of thrombin so it can't do that interaction. Simple, okay? So this is the trial, and I want to talk about this a little bit because of the labeling is different than the trial, and there's some issues that we should talk about. So this is our typical trial, isn't it? We've got 18,000 patients in 3 arms, open label warfarin, blinded Dabigatran 110 BID or 150 BID, followed for about 2 years, and the endpoint was to be stroke and systemic embolization that didn't result in stroke. 4 patients with non-valvular atrial fibrillation, and we'll talk about what that actually means. So it was a non-inferiority trial. That was the idea of the trial. They wanted to prove that it was equivalent to warfarin. 50% of the patients were vitamin K antagonist naive. They hadn't been on warfarin before. Again, stroke and systemic emboli. And then the safety outcome was obviously major bleeding. So the inclusion criteria, we wanted to get CHADS-2 scores that were in the 2 range or higher. So non-valvular persistent paroxysmal or permanent atrial fib, so it could be any type of AFib. And you needed to have 1 or more additional risk factors. So previous stroke or TIA would work. Low EF, with or without heart failure, age over 75. If you were over 65, you had to have at least diabetes, coronary disease, or hypertension. So, again, the goal was to try to get a CHADS-2 score of 2 or greater. The exclusion was significant valvular disease, i.e., during the course of the trial, 2 years, that there wasn't going to need to be some intervention to the valve. And that's what they meant by non-valvular AF. But it doesn't mean on echo that there wasn't 2+ MR. It didn't mean that at all. Okay, so that was the trial. The other part of the trial I want you to look at was the fact that if there was a renal impairment, if the estimated creatinine clearance was less than 30 cc's per minute, they were excluded from the trial. Now, we'll talk about the labeling here in a second. And the net result of the trial for the 150 BID dose was a reduction of 35% in the endpoints of stroke and systemic emboli. So it was a statistically significant improvement over warfarin. This wasn't just non-inferior, it was superior to warfarin. Now, what you don't see in here, and these are the slides from the Dabigatran folks, is the 110 BID dose because the FDA decided not to release the 110 BID dose. Instead, what they released is 75 BID for people with creatinine clearances of 15 to 30 cc, which wasn't even studied in the clinical trial. So it was kind of interesting. And the nice thing about the 110 BID dose, for older folks, it was associated with a lower bleeding risk than 150 BID was. So they ended up with a label warning, if you're over 75, be careful with 150 BID because the bleeding risk is higher. So it really took one tool out of our toolbox, and there's a lot going on to try to get that 110 BID dose back on the as a choice for us. So it is interesting what happens. So if we take a look at what actually happened in this trial, so here is red is warfarin and blue is Dabigatran. There was a statistically significant decrease in the endpoint of stroke. Major bleeding was not statistically different. Hemorrhagic stroke was significantly different, and this is true of all 3 of the agents that are nearing, well, rivaroxaban is released now, but it's also true for apixaban. So this is a big deal. These are bad strokes. MI, there was a little signal. It was a numerical difference, but it wasn't statistically significant. We'll talk about that. And it was very close to being a mortality difference. 0.051 was the p-value for that, and that's been the case for apixaban too. So there is a signal that suggests improved mortality. So at what cost? What I wanted to show you here, so we had 6,000 people in each of these arms, and this is the number of events. So these are strokes, the adjudicated strokes. So 186 in warfarin, 122 with Dabigatran, ischemic strokes, hemorrhagic strokes, and systemic emboli, no different. So that's why that trial is as large as it is to power that type of event rate. So what do we see as far as efficacy? It went across all lines. The only one that kind of crossed over just a little bit was prior stroke. But there's nothing that's way over here saying that warfarin is better. and at what cost. So if we had 189 strokes, that's our efficacy. Our safety is in that same population, we had 2,166 bleeds. Now, a lot of those were minor bleeds, right? But it's still, these drugs are, both of them are very good at causing bleeding, and their major bleed rate was about 3 to 4% in life-threatening bleeds. Since Dabigatran was released, I don't know if you saw this over the last few weeks, there's been some controversy about the bleeding risk, and there have been 250 fatal bleeds recorded worldwide for Dabigatran. But that frequency is less than the trial. So it's not like the trial did something magic to prevent lethal bleeds. But any of these drugs can cause lethal bleeding. We've all had patients on warfarin that have had lethal bleeding. Okay, so again, it's the reason to risk stratify these folks. That's why I spend so much time up front with that. If somebody doesn't need one of these agents, you should not give them the agent, whether it be Dabigatran or the warfarin. All right. So basically, here is the instruction that we talked about before. So if your creatinine clearance is greater than 30, it's 150 milligrams twice a day. If it's 15 to 30, 75 twice a day. I think this is a really bad idea. So if I had also a creatinine clearance of 35, where does that come from? So these are all, you know, estimated GFRs that come on the lab sheet that's based on an algorithm that's based on populations but has nothing to do with Mrs. Jones sitting in front of you who's 82 years old, who, because she's 82 years old, has an eGFR that may not be correct. And the one stroke that I've had on Dabigatran was exactly this type of a situation where somebody, I went to order 150 BID, the pharmacy called me and said, you know, we think Helen ought to have 75 BID because her eGFR is 29, and she was 85 years old. And she came back later with a stroke, and we checked her activated PTT, and she was not inhibited at all on these lower doses. So this is a weakness with these compounds, and we don't have a great measurement tool. And there's some things in development. So again, we'll spend just preliminary time on this about what to do if somebody bleeds. So somebody is on Dabigatran or apixaban, and they come in bleeding. What do you do? So what's in the works, which we don't have right now, is a monoclonal antibody that will hold on to these drugs and turn them off like that. And so that's about 2 years out. So for both the 10A inhibitors and the direct thrombin inhibitors, that will be the case in the near future, and that will be wonderful. You just give them that, and then you can go ahead and do what you want to do. So now if somebody comes in bleeding on the drug, it's mild bleeding, we do what we always do. You know, you can stop or at least delay giving the drug for a while. Local control measures, not a big deal. Moderately severe bleeding, identify the site, and I'm sure you do the same thing. Somebody comes in that, whether it be pyridine therapy or whether it be warfarin therapy or Dabigatran, I think it's important to get GI involved early to know where there's the bleeding source, what you can do about it, which is what we do, and then just the usual resuscitation methods. But if it's life-threatening, it's a little bit different. One of the nice things about this molecule is that it's dialyzable. It's not really protein bound very much, so you could dialyze the patient. If they had just taken drug, you could give them some activated charcoal. But you basically need to wait, and the half-life of Dabigatran is between 12 and 17 hours, depending on renal function. So it'll hang around for a while, but it will go away. Okay, so it's a problem. Now, you can use these purified prothrombin complex concentrates, and that may work if you look at the trials where they're used in normal, healthy volunteers. They don't work because if you think about where we're acting, we're down here on thrombin, and they're acting up here. So it's very anecdotal data. I think if somebody's bleeding, you go ahead and give it to them, but I'm not sure that there's a lot of science behind that. Okay, so that's the reality. So what are the characteristics of these newer oral anticoagulants? So we have Dabigatran, rivaroxaban came out a few weeks ago. Apixaban is in trials and is moving down the road very, very nicely. All three of these are great drugs. There's Edoxaban, which is kind of have a delayed clinical trial, but it will come out. And this guy's kind of stuck somewhere, I'm not sure where. So this is the only direct thrombin inhibitor. These are 10A inhibitors. And you can see the bioavailability. The protein binding is important. Rivaroxaban is not a drug you can dialyze to get rid of. The half-life, this is a very interesting thing. The Dabigatran's half-life is in this range. Rivaroxaban's is in this range. So, but it's marketed as a once-daily drug. So the clinical trial, the Rocket AF trial that we'll talk about in a second, was non-inferior to warfarin, but was not superior, and they chose a once-a-day drug that my personal belief that it was chosen by the marketing department, and it wasn't chosen by their pharmacologist. It makes no sense to give a T1/2 5 to 9 hour drug once a day. The rest of them are appropriately BID. This is a longer half-life drug. Once a day is reasonable. So, renal excretion, Dabigatran is renally excreted, and these are less so. So we're going to have some options. So if somebody has renal failure, you can't use this drug. Okay. Not a lot of drug-drug interaction with these agents. So rivaroxaban, again, it's a 10A inhibitor, not a direct thrombin inhibitor. Same kind of issue in that you can get people anticoagulated very quickly. It truly is BID dosing. And the rest of that, there's a little bit of a SNP interaction, but it's minimal, and a third of it's renally excreted. So the Rocket AF trial was the same type of thing, although it had blinded warfarin versus what the Dabigatran trial was. So there was a large trial, and that was the construction. If the patients had renal dysfunction, they down-dosed the drug a little bit. A long trial, 2 years. Same type of endpoint, same type of safety endpoint. And again, the trial looks very, very similar. Warfarin versus rivaroxaban. A little lower event rate, major bleeding, and mortality. So it was really a non-inferior trial. It was not a superior trial. So there is, but again, it had the same signal here for intracranial hemorrhage that we did before. And then apixaban was just presented at the European meetings this last summer. A very exciting drug, and again, the same type of situation. We talked about a little less in the way of renal effect. And this trial was a little smaller. So this was the initial trial that was actually against aspirin alone. These were people that were deemed not to be able to take aspirin, so this is kind of not really fair in a way. But it was a highly positive trial. So here's the event rate with apixaban, and here is with aspirin alone. But what's interesting is that there wasn't a heck of a lot of more bleeding with apixaban than there was with aspirin alone. So that was a little surprising. But there was a clear-cut mortality advantage. And then they did a trial, Aristotle, which was just released, again, looking at a large trial, a couple of different doses of apixaban, and you down-dose based upon these factors. And again, it was a non-inferiority trial, and it was found to be superior, very similar data to the Dabigatran trial. Same signal here. And there was a survival advantage. Remember, the P on the Dabigatran trial was 0.51. This was 0.47. So I think these are basically identical agents. This one has less renal effect, so it might be easier. And this scattergram is basically to show you this is apixaban versus warfarin, and the apixaban was really a very good drug. Okay, so now all of these drugs, if you break down the trials and you look at people that spend a lot of time in target range, there really isn't a difference between warfarin and these agents. But that's the problem, is how do you know where your patient is going to go? So I think perfectly controlled warfarin, great kinetics, there's no reason to make any changes. All right. Come on, I didn't want to do that. All right, so we've kind of gone all over that, and this is just a recap of what we were talking about earlier for you to know. Okay. So, what do we know about these agents at this point in time? So we know that they're as effective or more so than warfarin for clot prophylaxis. Without a need for monitoring, there's a similar decreased risk of major bleeding. There may be a survival advantage here, and what we know is that they don't obviate the risk of bleeding. The reversal agents are to come. It's like a software upgrade that needs to happen that hasn't happened yet. We know that monitoring is desirable. If we want to know if the patient is being compliant, we want to know that it's safe to go ahead and do neurosurgery and the drug is gone, we'd like to be able to monitor these. And these are not generic drugs. So it may be cost-effective to the healthcare system when you consider the monitoring part of the equation, or unnecessary bleeds or unnecessary strokes. But as far as the patient's out-of-pocket cost, that's really what dictates whether we use the drug or not, right, what their copay is. So most of these drugs have been marketed fairly successfully with low copays. The other question is, what's the rebound effect? So one of the weird things about the Rocket AF trial is that when they stopped the drug at the end of the trial to go back to warfarin, they didn't do a bridging strategy, and there was a sudden increase in events. And there is a question that if you block thrombin, then you take the agent away, you generate transiently more thrombin than you would normally generate, so there's a rebound effect that's been measured, and the same is true for 10A. So it's a bit of an issue that we need to understand a little bit better. So how do you monitor these drugs? So we've been wrestling with this at our place, and so the best tool to monitor Dabigatran, to get a level and say that this corresponds to the blood level, is an eccrine clotting time, ECT, impossible to get. 6 days becomes not useful. You can do a thrombin time, but there's not a standardized thrombin time. Thrombin time has a great amplified signal to look at blood levels of the Dabigatran. So you could theoretically have a thrombin time and say, okay, based on that, this is a patient on the Dabigatran, comes in with a stroke, based on this level, it's okay to get CPA. You'd like to be able to answer that kind of question. Or it's down to a baseline level, we can go ahead and do a highly risky surgery like neurosurgery. So we've developed that, and we've checked blood levels, and we think that that's ready to go, but it's not a nationally available, here's how you do it, and if this level means this, means this, means this. You can just get an activated PTT, and if it's normal, then either A, the patient's not taking the drug, or there's so little in the system that it's not affecting the system. But it's not a very amplified signal, and ProTime's worthless. So that's a bit of a problem. You know, non-compliance BID drug in a guy who wants to go hunting, you know, it's a big deal. So that's a bit of an issue. So I think we will see in the not-too-distant future more of a unified way. Here's how you check it, and here's what it means, and based on this value, here's what you do. So how do you get somebody ready for surgery that has been on Dabigatran? Well, a lot depends on what the risk of bleeding with the surgery is and what the renal function is. So if the renal function is perfectly normal, you stop the drug, 24 hours later you can go ahead to surgery and you're going to be fine. If there's a higher risk of bleeding with the surgery, again, neurosurgery would be an example, you might want to wait 2 days for somebody that's on the drug who has normal renal function. The problem is, what if the eGFR is 35? A bit of an issue. So there are challenges here, and so oftentimes what we're going to say is suggest to patients, well, maybe we could go use this new drug. The other factor, which is really interesting, there's a lot of folks that go into the TOAG clinic, it's the highlight of their month. You know, they go see Sally Sue and sit down and have Sally Sue talk to them. You're not going to talk to them out of work. That's their life. So I'm going to stop and see what questions you have. So is anybody using these agents, either Rivaroxaban or
I'm in on the hospital with increased MI with big meta-analysis with Luke and some of the other problems.
Well, it's numbers. There were more MIs numerically than with warfarin in the Rely trial. It was not statistically significant. The P was 0.12. So, is it real or not? So, there's two hypotheses that I've heard. So, I think what's clearly true is that it doesn't cause MI. But what we know from the 70s is that warfarin is somewhat effective in preventing recurrent MI. And we've kind of gotten away from using that drug because nobody likes to use warfarin, right? So it is somewhat effective, and it's possible that warfarin is somewhat more effective than Dabigatran in preventing MI. But it's you know, hypothesis generated. But it was a signal that came out.
Wouldn't the same hold true for the NA? I mean, if you consider that this factors of the issue in the brain or decreasing and in plaque in the coronary artery, then the
Well, as far as the intracerebral hemorrhage part of this is concerned?
I think tissue factor 7-8 potentially be playing a role, and there's going to be a different perspective. At least one cause of thrombus.
So this is very interesting. So it looks like the 7A plays a positive role in vascular repair, and that's thought to be in the brain particularly. So because the 10A inhibitors are blocking downstream from 7A, 7A levels are normal in people who are on a 10A inhibitor or a direct thrombin inhibitor, and they're not normal on people that receive warfarin. So the theory right now is that the reason there's fewer intracerebral hemorrhages using these drugs is that the 7A levels are normal, and therefore we have better repair. It's probably true. I think it's intriguing. So the other explanation, obviously, is that there are people that are running INRs of 5 and 6, and they're at higher risk of bleeding, and I think that's probably also contributing to that observation. That's
the European CHAD score takes gender into account where the CHAD scores sort of and I think if you look at the framing data, plug that in there, just remember this.
Well, I think you're right. So again, but I think you're right. The risks of bleeding are also somewhat higher, interestingly. So yeah, I think it plays also then a role toward the far end of the curve where there are more factors involved, and I think it helps to mute that. I think that logarithmic curve that you see with CHAD2 is probably deceptive. I mean, an 18% risk per year of stroke is probably not true.
You were going to comment on the valve disease?
Right. So if it's not hemodynamically significant valvular disease, then these trials address that issue. So again, though, the way if you go write a prescription, you know, for non-valvular atrial fibrillation, you're better off writing that on the prescription because otherwise they're going to come back and say, well, this patient also has a diagnosis of mitral regurgitation. So all mitral regurg isn't created equal. So this is our era, though, right? So when the drug comes out with a given label, that's what we do. And it used to be that a drug would come out and then the docs would figure out how to use it. And now we kind of are afraid to do that anymore. And so we have to wait for clinical trials. So with prosthetic aortic valves, a mitral valve, can you use it? Not at this point in time because there's no indication for that. The trial's underway. It may take a couple of years. Use of these drugs as a bridging agent. I mean, this is really intriguing, right? Why use Lovenox, which we all hate, when you can use this drug for a period of time as a bridging agent? It hasn't been studied. It needs to be studied. So I think all of these gray zone areas where these drugs are going to be very, very useful, I think, we're going to have to wait until the trials are done. In the old days, we would have just done it, maybe did some registry data and tried to collect that, and you know.
Yeah, how are the devices going to play out? Where does they still
Yeah, that's intriguing. So you know, there are several ways to attack the atrial appendage. There are several inside the atrial appendage devices, such as Watchman. There are some through the pericardium approaches to snare the atrial appendage and exclude it from the circulation. We know that 90+% of thrombi and atrial fibrillation come from the left atrial appendage. So it makes sense. We as interventionalists love to do stuff. The problem with the trial for Watchman is that there were a fair number of atrial appendages that were violated and pericardial effusions, but there was a learning curve. Once you got through that, it seems to be very, very safe. The FDA has been extremely worried about the learning curve and how to do that. And then we have reimbursement issues. Who's going to pay for what? So you might think of an AFib ablation. You're already across the interatrial septum. Why not do the ablation, leave a Watchman device behind, and, you know, that would be great. Makes a lot of sense, but it's probably not going to get paid for. Or it will be part of a procedure, and they're going to charge you, you know, $3,000 for the little device that you leave behind. So I don't know. And then how many patients can you talk into having a transseptal catheterization to put something in their atrial appendage when they can take a drug that doesn't need to be monitored, even though there's a bleeding risk? So, you know, I don't know. There's a lot of companies betting a lot of money that people are going to want to have their atrial appendage taken off. Well, what do you think? What do you think is?
Well, maybe you're the better ones.
Well, there's certainly a decent-sized population of patients who bet on a patient. They fall into that appropriate sweet spot for atrial appendage. The question is, how many 50-year-old hunters don't want to take pills are going to volunteer for this thing?
Whose CHADS 2 score is 0 or 1, right?
Exactly.
So it is a conundrum. The best people to do it have these low CHADS 2 scores. So, yeah, I don't know. And then what is the opinion of primary care versus wildly run-amok interventionalists that want to put devices in everybody? So if we don't see the patients in primary care, then we're not going to do it either. So I was speaking personally. Any other questions?
And how the Dabigatran level now that they measure in the lab?
No, but if you can actually measure, the level clearly correlates with the hemodynamic effect. So if you have the ability to get a Dabigatran level, then working with Boehringer, you ought to be able to figure out how active the drug is. So what's the turnaround time on that? You know. Yeah, so it can be very helpful. But it would.
I'll give you an example. 80-some-year-old lady who's graduating from 1.5 and she's not on overdose, and her level is higher than the recommended therapeutic level. What do you do about that? I mean, there's sort of, I suppose you could say maybe you should give her to her once a day and see what happens. I guess that's your. The other part goes back to the effectiveness of ACE in fact reliant on people. Some people are walking around with private numbers. You don't always assume that you need so much of something. You don't really know that. It's like in a warfarin. So we sort of figured out that came in and we're at 1.7 or 1.8. That didn't mean that we had 2 didn't have a stroke.
Right.
You know what I mean?
That'd be a good application, though, because I think, you know, unfortunately, this is one-size-fits-all pharmacology, which I think makes all of us uncomfortable. So there's a lot of difference between an EGFR of 31 and 60. And so their cut part is absolutely empiric at 30. So that would be a very good use. So if you knew that this blood level of Dabigatran corresponded to this effectiveness in anticoagulation, and you could hit that sweet spot by measuring that in a steady-state way, that would be very helpful.
Or at least you'd know that 85-year-old that you were giving too much.
Or not enough.
Or not enough.
Yeah, I think that's a very good point. Yes, sir.
Are you just smart about the GID?
No, I was just a political comment.
Oh.
Yeah, no, we're doing it by the label. Yeah, it just disturbs me. Political comment.
That account takes superiority.
Well, you know, honestly, I think that's probably true. I
think that's true. I hate to see such a wide swing, and that's the problem. So there's going to be a period of the day that person is not anticoagulated. So it is what it is, right?
I have seen one stroke on a guy in big.
So there's another trial that I didn't talk about that has to do with the use of rivaroxaban in acute coronary syndrome. It was a very positive trial. Geez, I hate to, we hate to have people on triple therapy, but most of these folks were on dual antiplatelet therapy plus rivaroxaban and a low dose, 2.5 milligram dose. And it was positive. It was improved mortality rate. So it's more to come, and I think they duplicated, but it's, I think it's something I wish wasn't positive, but now we're going to have to deal with this issue of more intense anticoagulation, and it's something we want to do about. But it's intriguing. It makes a little bit of sense, at the end of the day.
Seems like one of the issues, really, that the number of people who take anticoagulation are not taking anticoagulation, and drugs. Well, comment on it on that problem. Stratification. We're really that group that's not being. You don't have the data to support it. Right? Yeah, I look at others that have problems.
Well, you knew that the trial was going to be positive with an effective drug like apixaban versus aspirin alone, right? So that was my only derogatory comment about that. Right.
Are they really the
No. I think, personally, I think that anybody who's a candidate for warfarin is a candidate for these agents, honestly, and probably for whatever application you use warfarin for. Now, we don't have the clinical trials to support all of that, but if you've got a St. Jude aortic valve, it's probably just as well treated, or if not better, with one of these agents than with warfarin, but we can't do that yet. So I think because the pharmacology is very clean, the treatment point on the cascade is very known, the kinetics are known, these are just better drugs. So at some point in time, I think that warfarin will probably just go away, particularly when we have these monoclonal antibodies. We can just go, boom, that drug is reversed, end of story, and that's going to be very, very neat. But so 3 or 4 years from now, I think warfarin is going to be in a marked decline. Oh, hello.
The leader has turned lecture off, and your line has been unmuted.
Hi, Laura. Are you there?
Oh, yeah.
Did you have a comment?
Oh, I didn't know I was going to be put on speaker. I just had a comment that Abbott does now have a Dabigatran level available. It basically correlates to the 2A levels, and it's available for ordering now, and there's more information that's going to be coming out in a medical letter in the next couple months.
Well, that's great. Yeah, we were talking about that a minute ago, and that's intriguing. So we're going to have to find out about that test so we can do it at home as well. Thank you.
Yep, thanks.
Okay, guys, thank you very much. Appreciate it.